Welcome to the latest episode of the AAOS Now podcast, brought to you by the American Academy of Orthopaedic Surgeons. This monthly podcast series focuses on hotly debated issues and controversial trends in orthopedic surgery. Each episode presents nuanced perspectives to inspire further discourse, inform your decision-making, and maybe even change your mind.
Hi, I'm Dr. Doug Lundy, Deputy Editor of AAOS Now, and I'll be your host on this episode of the AAOS Now podcast. I'm pleased to be joined today by Dr. David Martin, Executive Director of the American Board of Orthopaedic Surgery, and Dr. Ellen Lutnick, a PGY5 resident at the University of Buffalo, to discuss the ABOS Knowledge, Skills, and Behavior program. Dr. Martin and Dr. Lutnick, welcome to the AAOS Now podcast.
Thanks. It's great to be here.
Thanks for having me.
All right. Thanks, y'all. All right, Dr. Martin, let's start with you. Now, the ABOS launched the Knowledge, Skills, and Behavior program in 2018. And in 2025, they made it a requirement for ACGME-accredited orthopedic surgery residency programs who plan to take the Part I exam. For our listeners who may not be aware, can you start off by explaining what it is and why did the ABOS decide to create it?
Sure, that's a great question. And I think it came from really two areas. Number one is something that's been around really since the 1950s, is competency-based medical education. And the Halstead apprenticeship surgical education model really doesn't scale. And individuals since the 50s have looked into competency-based medical education. We have evolved into a time-based program, and as a board, education leaders such as Ann Van Heest and Larry Marsh looked at residency programs and said, we really don't have good measures to know as residents complete their education and enter our board certification program, we really don't know where they stand in surgical skills, in orthopedic knowledge, and in professionalism. And that was borne out by those individuals looking into ways that we could measure that as residents entered our board certification program. The ACGME accredits residency, so the educational programs are judged, but residents really spent 5 years, and we hoped that in 5 years, they gained the appropriate knowledge, the appropriate surgical skills, and the appropriate professional behavior, and were signed off on by their program directors to enter board certification. So the board set out to come up with measures in those areas, in orthopedic knowledge, in surgical skills, and in professional behavior. And as competency-based medical education moved along, we wanted to develop our own program as opposed to have someone else develop a program and have us roll that out.
So why did the ABOS opt to make it a requirement?
Yeah, another great question. We were at this for about 10 years, and we felt like the program was a good one. We felt that it gave residents formative feedback. We wanted residents to be in charge of their own education, and we needed another dimension to measure residents as they move through their educational process other than just time, and felt like to require participation in the program and allow residents to control the program would allow them to be more in charge of their own education. Certainly, there's a lot of stressors on surgical education. The electronic medical record solved a lot of problems, caused a lot of others. The 80-hour work week makes sense, but puts stress on surgical education. And so we really wanted to make sure that residents were getting the formative feedback that they needed as they progressed through residency. And that moved us to require that those participation levels for residents as they move through their educational program.
Was there any resistance to the idea of required KSB?
Yeah, absolutely. Absolutely, yes. I think, as I'm sure Dr. Lutnick will outline, residents and orthopedic attending surgeons have plenty to do and didn't need one more thing tossed onto their plate. What we tried to do was link our program with case entry system for the ACGME. So residents for a long time have had to enter all their cases to the ACGME. And we wanted our case entry system to pair with the ACGME. So we worked very closely with the ACGME. We actually are the first and still the only board in the United States to have a program that allows residents to enter their cases into our system, and then that flows directly to the ACGME. And what I tasked our people with and what we've come up with, and I hope Dr. Lutnick will agree, is our case entry system is at least as slick, if not a little bit slicker and easier than the ACGME's entry system. And we still get them all the information they need and allow residents to then utilize those surgical cases to get surgical skills evaluations. So that was the way we decreased the burden. And then we want the program to be valuable enough to get residents formative feedback. We have plenty of summative feedback, right? Our Part I examination, our
Right.
Part II examination, that's summative feedback. That gets to a plus minus pass-fail decision. This is formative feedback that's meant to give the residents feedback that they can utilize to improve and give programs feedback on how they're doing in educating residents and allow residents to see maybe they're pretty good in orthopedic knowledge, but not so accomplished in surgical skills. They can focus there. Maybe the professionalism identifies outliers. We'll talk about that, but it allows residents to gauge their education as they move through residency education. It gives, again, another dimension besides just 5 years sort of swishing around a tea bag is what Ann Van Hees said. We just take a resident, throw them into the milieu, swish you around like a tea bag, and hopefully at the end, you're a pretty good cup of tea. This gives not only residents, but it gives the faculty measures. So that was our goal, and we required it. I would just start out by saying every single resident that registered and was ready to take the Part I examination met the requirements and was able to sit for the examination. So there were several residents that received phone calls from me over that last week, but every resident made their numbers, and I hope the feedback was valuable. And now I'm hoping to get some feedback, and the board is to make the program better.
Yeah, I really like your delineation of formative versus summative assessment and feedback. That is so valuable. All right, Dr. Lutnick, at what point did your training at Buffalo adopt the KSP program?
Yeah, so we rolled it out. It was introduced 2 years ago. So my PGY 3 year, I think halfway through the year, everyone kind of downloaded the app. It wasn't required at that point because I think that graduating chief class didn't have a requirement for the assessments to sit for their boards, but it was recommended highly that you start practicing using it, both I think for the residents to get used to requesting feedback and also logging our cases that way, but also to get our attendings used to what is this text message showing up on my phone or what is this email showing up in our system and do I have to do something about it? So that year was a kind of a trial year, but last year was, obviously the year that there was a requirement to sit for the board. So that was when it was more formally kind of enforced by the department. I think there was at least one resident that I can think of from our program who absolutely made it in, but I think our program director kind of told him to log his cases as rapidly as possible towards the end there, not to blow him in or anything. He did well, and he was able to sit for the boards, which is good. And I can definitely corroborate Dr. Martin. I do think that from a case logging standpoint, not even talking about the feedback standpoint yet, the ABOS app is actually, once we got over the hump of adopting something new and just doing something different that was not in our routine, I think it actually is easier now to log cases. It takes me more time to look up the appropriate CPT codes than it does to actually log the case. So it is convenient in that sense. And it's nice that it's an app that you can do on your phone.
Now, the Buffalo program is a tremendous program. Were you receiving regular feedback prior to adopting the ABOS KSP program?
Yeah, I think it's depending on who you're working with and what maybe your own style is as a learner and what your attending styles are as teachers. But I would say I think our department does a really good job of providing feedback to residents, and it looks different depending on what rotation you're on, what level you're working at, who you're working with, what kind of relationship you have with that person. Internal to our own, we obviously have verbal feedback. There's some attendings who do formal beginning and middle and end of the block rotation, sit down feedback sessions with residents. There's some attendings who will maybe call you out in front of the whole OR more regularly, and it's tough feedback to hear, but you're glad to get it because it makes you better. There's some attendings who you don't really hear much from until you get to the end of the rotation and like specifically ask them for feedback. And probably I would say if you're a resident who is seeking out feedback and you're asking your attendings or telling them what your goals are, they're probably more responsive, and I've found in my experience more responsive and more direct with their feedback with regards to what your specific goals of the rotation is with them. We do also have electronic forms that we're required through our university to fill out for feedback through a separate hub other than ABOS. So to Dr. Martin's point, there definitely, I think, is some survey fatigue happening between the attendings and the residents. But I think our department tends to do a good job, especially with verbal feedback, and that tends to be the more effective form of communication.
What was your initial feelings about the required status of KSB?
So I know at first, myself included, the residents were kind of asking the same questions that, you just asked Dr. Martin, like, what is the point of this and why are we doing this? I think when it became, when it was advertised and known that it was required to sit for your boards, I think the next questions that people were asking were, okay, if I get a certain number of, surveys filled out from attendings or feedback forms filled out by attendings, is that somehow going to affect my eligibility based on my scores? Like if someone's giving me feedback saying I really need to improve the work that I'm doing, maybe it's a case that's really challenging or an attending that I don't work with frequently, or I just was not prepared in the way that I wanted to be. Is that going to mean, like, is there some sort of score? And it's my understanding that that's not the case, and you just have to have a certain number of feedback forms filled out. But I think this year it's been a little bit more, it's built into our routine a little bit better, but there definitely was some resistance. And I think there's still some questions about that. Like what are the results of these surveys long-term? Is that going to carry through for our career?
Okay. Well, let's talk about how KSB has been incorporated into your day-to-day training. Is it time consuming to request either a surgical skills or professional behavior assessment?
No, I would say it's a very easy, like from a system standpoint, the app is really easy to use. Again, it usually takes me more time to find the right CPT code than it does to actually log the case. And the evaluation is literally just a checkbox saying, do you want to send this feedback survey to this attending? You have to do it within a certain time frame. So it honestly has helped me to be more diligent about logging my cases the same day, because I know that I only have, I think it's 48 hours to request feedback from attendings if I want to get those feedback forms filled out. And it's also easier to do it, on time, but we all procrastinate in different ways probably, but definitely not time consuming. I will say it, for me, it's also been a little bit more effective, and I've gotten better feedback from attendings, and maybe even the way that I found it to be most effective is if I request the feedback before the case starts. So I log the case before the case starts, the attending gets the notification on their phone, and that is kind of a signal and a conversation starter with that attending where they know that I'm going to be seeking out formal feedback after the case. Maybe they give me more of an opportunity to be involved to get enough exposure to that case to get good feedback, but also maybe they're paying attention to what I'm doing in the case a little bit more closely. So I found that to be probably the most effective, at least for me.
And it's probably good practice because you'll be chasing CPT codes the rest of your professional life. How do you decide which surgical cases to submit for surgical skills assessments?
That's a good question. I think for me, if I'm requesting an evaluation after the fact, it's probably I'm going to request them on the cases that I feel like I did more in that case, so I'd be able to get better feedback. Or sometimes it's a case where, honestly, like a case where I know that I was struggling and the attending was giving me maybe verbal feedback and cues in the OR just to see how that's reflected on a score form. Or sometimes, for my own sake as a trainee, if I'm requesting that feedback in advance of starting the case, that's me hopefully signaling to the attending, I think this is a case that I am prepared for and a case that I'm hoping to get your feedback on, but then also a case that I'm really hoping that I'll have an opportunity to do more in that case in order to garner that feedback. I think, first starting out as a PGY3 requesting these, I think it was just any case that I felt like I was doing more. But now that as a chief, I feel like I've been paying a little bit more attention to the differences between how my attendings score the feedback forms. So some attendings will score you based on your level of residency. Some attendings are a little bit more critical. Some of them, actually write in the free text box and give you some feedback that maybe you didn't get in the operating room. So maybe seeking out those forms from attendings that I know are going to be filling them out a little bit more thoughtfully. So it's hopefully feedback that's a good learning point for me.
Yeah, our residents specifically say it's the actual free text that really helps them the most on that.
Yeah.
Dr. Martin, professional
That's what we
behavior is
covered.
assessed through faculty evaluations at the end of each rotation and at a yearly 360-degree professional behavior assessment. And a study published in 2020 found that the behavior assessment tool was effective at assessing resident professional behavior. How are the assessment results being used by residency programs?
Yeah, that's a great question. What we saw when we looked at this tool is that it identifies outliers. Most residents, from a surgical skill standpoint, start at a level and progress upward throughout residency. Professionalism is really not that. People don't arrive with zero professionalism and poor behavior and get to good behavior. The tool really identifies outliers. And I think that's the value, is to identify outliers to the program director, and then the program director can decide what to do with that information. The AOA Cord group is working to try and get to educational modules to help in those areas so that we in fact offer something for those residents who have issues in those areas. Many programs have that, many institutions have that. And so hopefully that's identified early on and doesn't become a problem later. Because what I tell residents and faculty members this, in my role as executive director, I spend an inordinate amount of my time dealing with orthopedic surgeons with problems in the professional behavior arena. And so to get that right early on, I think it will be very important. And that speaks a little bit to the data. I know Dr. Lutnick alluded to that. Right now, the data goes to the program and the resident. We are certainly collecting the data in a de-identified fashion, and we're collecting a lot of data. And we need to look at that and try and figure out what it means and where to go with that data and where to go next, not only with our programs, but with residency education. We want to look at, are those professional behavior outliers that are identified in residency, do they show up down the line as professional behavior issues later on? And can we do something in between to prevent that? And I think right now the ratings are all formative. And, I joke when people ask that question, I have a whiteboard in my office and I have the names up there. Like when Dr. Lutnick does a bad job on a shoulder scope, I just write that up there. Yeah,
Oh, no.
we don't. I mean, there are 4,000 residents who all did at least, there's 1,000 that graduated, who all did at least 80 professional surgical skills assessments. So when you multiply that out, we have like huge data. And I think we are looking to residency programs and to residents. So could you do, someone said, well, which cases? And I said, well, you can do the next 80 carpal tunnels in a row with your favorite attending. That won't help you very much, but it will, satisfy our requirement. And should you do like 80 in PGY2 and 160 in PGY3, then less PGY4 or what? We are allowing people to average those. We're sort of looking for which cases maybe should be evaluated. And now we get to that C word, curriculum, right? Should at some point, yes, down the line, and this will be well down the line when we have data, should we say, hey, finishing residents ought to get to this level with a hip fracture. They ought to get to this level with a femur fracture. They ought to get to this level with a carpal tunnel. What are those cases? And that goes back to curriculum, and that's a whole other debate. Should we have a diverse training or specialized training, and when does that happen? That's a whole other, right now we have a 5+1 program of education, and that's another debate. We don't want to change that, 5 years right now. Could people get ready at 4 or ready at 6 or what? That's again down the line. So we may use that data at some point, but right now it's formative, and you hit on it exactly. Hey, Dr. Lundy, we're going to do this femur fracture together. I did one with Dr. Smith last week, and he rated me pretty well. I'd like to have you rate me in this, and I'd really like to work on this area. That clearly there's not always time for that, but that's the place where we want to go with that. down the line. So that's a long answer to your question, but we're trying to identify outliers with the professional behavior assessments.
Yeah, no, thank you. That was very, very informative. Dr. Lutnick, what was the behavioral assessment process like for you? And did it tell you anything about yourself that you didn't already know?
So the behavioral assessments, as a resident, and correct me if I'm wrong, we don't actually get the results of each individual assessment, but it is reflected, I believe, because our department gets the results. It's reflected in our 360-degree review that our department does, maybe external to ABOS, but that's in our UBGME system. So, I think that I don't know if I've noticed a difference in the ABOS KSB professional assessments compared to the 360 reviews that we were required to do through our university previously. But I will say in general, the overall kind of assessments we have done, I've gotten assessed by my co-residents and by attendings, and I've been able to see that feedback in aggregate totally de-identified. And I will say, I think that the feedback I've gotten there is helpful because it's not just, can you do this surgery or can you do, I might think that I'm a very friendly person and that I am a good leader and that I can take charge of a room and do what needs to be done. And sometimes that might be interpreted in the way that I intend it, but it might also be interpreted in a way that's abrasive or not collaborative. And so, when I have received feedback in that realm, it has made me reflect. I don't know if you do the best you can with that reflection, but it's made me reflect and say, okay, if this is what I'm intending and this is how I'm being perceived, how do I bridge that gap in the times that it has happened?
Oh, I totally understand. That's very good. So, has the feedback you've received helped you become a better surgeon? And how so?
I think so. Yeah, I think being a surgeon, you have to be able to run a room. You also have to work with your hands. You also have to be able to counsel a patient who is hungry and tired and had other plans for their day and now is in your ER with a hip fracture at 2:00 in the morning and doesn't want to be there. And so it's a multifaceted job. And so I think, you can be really good in any one of those avenues, but you have to be the best you possibly can be at all of them. And I think kind of to Dr. Martin's point that you're saying before of what the goals of this program is, I think what this has, at least in our program, it's kind of put more of a spotlight on how we deliver feedback. I know our APD actually started a study looking at how residents and attendings perceive the types of feedback that we use. This is kind of in response to KSB this past year. And we found that residents and attendings really like the verbal feedback and don't necessarily like the written feedback, and it's not as useful to them, which maybe is common sense. But even though the KSB is a written feedback form, I will say anecdotally, it seems like by sending that little link to someone, it does encourage that feedback. Maybe that even happens verbally. It starts that conversation. It kind of is the elephant in the room that gets the ball rolling, especially with attendings who maybe otherwise aren't quite as chatty with telling you what they think. So I would say that feedback is not just important for being a better surgeon as a trainee, it's essential.
So have you, when you've asked somebody for feedback, and I have my residents say, hey, I'm going to ask your feedback on this case. Do you feel more pressure or more under the gun under that scenario than a case that you have no intention of asking feedback from?
Yeah, of course. If I'm going to go up to my attending and say, I really want to do this case and I want your feedback. Yeah, well, it's probably not a case that I woke up that morning and said, oh, I guess we have this on the board. It's usually something that I've, prepared for, maybe even more so than I normally would try to prepare for our cases, or a case that I'm working with a lot of our joint surgeons right now. So maybe a case that I've done a couple different times, and now I'm specifically wanting you to reflect on how I'm doing and the progress that I've made over the couple weeks maybe that I've worked with any individual surgeon. But yeah, of course. And in some ways, that's maybe the reason to ask in advance of a case, is to light that fire and to put that pressure on yourself and see how you handle it, and then see what your attending lets you do in that setting.
Have you ever received feedback that you just abjectly did not agree with, and how'd you respond?
I 100% definitely. And I can think of a few specific times, but I think everyone has a different perspective. And even if it's feedback, I think what I've learned moving up through training, as a resident, you work with medical students for the first time. And I think when you have to give critical feedback maybe to a sub-intern medical student, someone auditioning with your rotation, where you know that maybe they're not doing well in some category. And if you don't tell them that, then they won't have a chance to improve and respond to that, then that's ultimately hurting that person. It takes a lot of effort to come up with critical feedback, and it also takes a lot of effort to deliver critical feedback. And I think finding myself in those shoes for the first time as a resident has given me a better appreciation for the people who give me critical feedback, wherever I'm at in my training. Even if I ultimately reflect on it and say, yeah, I'm not really sure that I agree with them, or maybe more often than not that I don't agree with them, but maybe that person just didn't understand the full situation that was happening or my perspective on what was going on. And maybe that's not ultimately the most important thing in this setting. Maybe I still need to work on X, Y, and Z. But even if there is some disagreement with that feedback, it's still something that I always reflect on and try to take it with a grain of salt, because it does take a lot of effort for someone to deliver feedback that is thoughtful and critical in a way that's, and even if someone's cranky or having a bad day or throwing instruments down, which, never happens anymore, it's still an opportunity for you to look at yourself critically and ask yourself, even if this person is saying something that I don't agree with, like what are the opportunities here to improve? Like, what can I take from this that turns this from a negative experience where I feel bad about what happened or I feel bad about the feedback that I got, and turn it into an experience where I say, okay, this happened, it wasn't awesome, but how can I learn from this and be better tomorrow?
Dr. Martin, is residency education, is that in the board's lane? Does that belong to the board?
Yeah. That's a great question. We are an assessment organization, and so when we looked at this and looked at, where surgical education was going, we said we're an assessment organization. And so we developed assessments. Now, we've been involved in educational requirements since 1934. And actually, the board, the ACGME grew out of the board movement. So we've been involved in the educational requirements for a long time. I think what we looked at here was we wanted to develop assessment tools that would be useful in the educational process. And now we're partnering with other organizations, the Academy, the AOA Cord, which is the residency directors, and the ACGME, to try and move surgical education forward. It's hard to train a surgeon. I know Dr. Lutnick said that. It's really hard to teach surgery. That's not an easy occupation. And so to try and, make that a little bit better, and we understand the survey fatigue and we're working on that. But, I think the assessment part of it is in our lane, and we certainly want to be part of the educational process. I mean, we're interested in safe, ethical, effective orthopedic care. And to get people to that spot, we want to be part of that solution.
Now, I'm sure you've received probably positive and negative feedback regarding the program over the last 8 years. How have you made adjustments to the program as a result of that feedback?
We've been at this for 10 years. Some might say we had the airplane take off and start flying maybe before it was finished, but we have taken a lot of feedback as far as how the app works, how the feedback goes to the attendings, how that comes back to residents, how it's reported. We've gotten a lot of feedback, both positive and negative, and then utilize that to continue to improve the program. And that's our goal, is to continue to make it better. And now, hopefully, with a year under our belt of the requirement, we surveyed residents, got a lot of feedback. We're going to respond to that, and we'll hopefully look at the data, survey them again, and continue to try and make it valuable. What we want to do is make the program valuable so that residents pass on to residents, hey, you need to do this. This is how you're going to get feedback. This is how you're going to put your cases into the ACGME. This will help you get to the goal of being, the slickest surgeon in the room, the smartest person in the room. That's sort of the goal. And the survey fatigue is real. We are working with the ACGME to try and move this towards functioning in concert with a little bit more easily, or perhaps taking the place of some of the other evaluations, including the milestones. Certainly they have a lot of data on the milestones, and we want to work together with them. So some of these map to the milestones, and we want to continue to work to try and decrease the survey fatigue, but still get you useful information.
That was great. Thank you. Dr. Lutnick, based on your ideas and on the discussions you've had with other residents, how could the program be more valuable to residents?
Yeah. So I actually, in advance of this podcast, I asked a couple of my co-residents, like, hey, I get to ask some people about the KSB program. Like, what are your thoughts? And almost uniformly, everyone wants to see the results of their professional behavior assessments on an individual basis, the same way that you see the KSB surgical results. And I can understand maybe why that's de-identified in an aggregate, because that's maybe a more sensitive topic and a little bit opaque than just a clear cut, you either were prepared for this case or not prepared for this case. But I think, maybe from our perspective, it is something that trainees want to know, even if it introduces hard conversations. Like, why are staff members responding to me in this way? How come I can, message a nurse and say, hey, give Tylenol to this patient, and my co-resident says the exact same thing on a secure text message, and one of us is that nurse's best friend and the other one is like somehow read as being sarcastic and dismissive. It's not always a clear-cut answer, but having people reflect to you about how you're doing in that regard, I think, is the only way that you improve. Kind of, again, to your point, Dr. Martin, it's not always easy to hear, but that is how you learn. And so I think that would be something that myself and my co-residents were curious about, even in the form of the 360 evaluation. So I do think it's helpful. But, from our perspective, if residents, maybe like myself, are starting to use the formal KSB assessments in advance of cases to maybe as a tool, less to look at the actual scores for however helpful those may be, but more to start that conversation with attendings, maybe the professional behavior assessments could also be used in that function.
Dr. Martin, will the ABOS move to a system where they require a certain score rather than just a certain number of requirements before the residents are allowed to, or the graduates are allowed to take Part 1?
Yeah, that's a great question. Certainly, as I talked about previously, I mean, I can see sort of way down the line if we can, identify a core group of procedures that residents ought to really achieve competence in, that we might get to there, but we have to collect a lot of data and agree on those procedures. We started out with a group of procedures that way, and then a group of procedures that residents ought to be exposed to, and then everything else was in a third category. But then the ACGME redid their case minimums, and we wanted our system to talk to their system. So we've sort of gone back to tailoring it towards the case minimums. But I think, looking at the case minimums and then looking at certain scores, right now they're all in aggregate, but I could see that eventually down the line. But right now, it's so valuable as formative feedback, and really to allow residents to be somewhat in charge of their own education. I think that's where we are right now. We have to look at the data before we even consider moving in that direction. It would be nice to be able to say, Dr. Lutnick, here's where you stand, and here's how surgeons did on whether it's our Part 1 or Part 2 examinations, or whether it's in practice or those types of things. That would be valuable information to you and your program to say, hey, look at these levels, now look at yours and get to there. I think that's hopefully, and again, that we need a lot more data, and we need to be able to evaluate the data. And that's something we're looking at right now, sort of how to do that.
Well, to wrap things up, Dr. Martin, is there anything else that listeners should know about the KSB program?
No, we're anxious to receive feedback, and we'll take that professional behavior to heart. That's something we've talked back and forth about, and how you protect the evaluators, but still get you useful information. So we'll certainly consider looking at that again. But any feedback, we're happy to receive.
And Dr. Lutnick, any pearls that you would send out to lower level residents or residents across the country about best practices in terms of engaging with the KSB program?
Yeah, I mean, I think the earlier you can start just logging your cases on a daily basis, you will thank yourself when you get that week of vacation. You're planning to catch up on 6 weeks of case logging. It adds up quicker than you think. And I think, especially if you're a junior resident starting off using the KSB evaluations rather than being introduced partially through your training, try to maybe map that data for yourself, whether or not it's formally or in your own head, and figure out how it works best for you. But again, I think in my experience, it's been really helpful to use it before cases I'm prepared for and request in advance to try to signal to the attending to start that conversation.
I actually don't have a whiteboard in my office. We were trying to get everybody.
I don't make the list.
We're trying to get everybody through. Yeah, we're trying to get everybody through. But really, if you have feedback, please don't hesitate to call. We're happy to hear that and try and make the program better.
All right, on that note, it's time to wrap things up. I'm Dr. Doug Lundy, and this has been the AAOS Now podcast. Dr. David Martin, Dr. Ellen Lutnick, thank you so much for joining me and sharing your insights on the ABOS Knowledge, Skills, and Behavior program.
Thank you so much.
Thank you.
Great conversation.
All right, thanks, y'all. And if you've enjoyed this episode and want more hot takes on controversial issues in orthopedic surgery, please follow the AAOS Now podcast and visit aaos.org/AAOS Now podcast.
Thank you for listening to this episode of the AAOS Now podcast, part of the AAOS Bone Beat Orthopedic podcast channel. Production and editing provided by MK Quinn Media. If you enjoyed this conversation and want to hear future hot takes on the issues that affect orthopedic surgeons, visit aaos.org/AAOS Now podcast and follow us today.